to see on your computers, I'm hoping if the sharing of the document works, a form that says Case History for ACNB 2014 Performance Exam. Good, I'm getting some yeses. All right, you also have access to this on your own website, on your own computers if you go to the ACNB website. This document starts out, it's like a patient history, or it is a patient history. And the patient history is one that a patient would have filled out on pre-examination paperwork. Just like you give them a set of paperwork, you're getting their insurance information, all of this, well, you also have them fill out a history form. So this history form is in the, this is just what their history would be. It's allowing me to go through it. And you're going to read through that. You're going to get one of these history forms for your exam. And it's going to be very similar to this. And you'll just read through it. And you'll be able to write on this one. You're going to get it in actual paper. And each one of you will get your own page. So you will be able to go through and read this and mark on it. But then you're going to go to the clarification flow chart. And you're actually going to get a blank one of these. And you're going to fill in questions that you want to ask that patient to clarify the problem that the patient's got. For example, this guy has a sore toe. His presenting complaint is a sore toe. So he comes in and has filled this out on his paperwork, and you start your questions off of the paperwork, looking at what he's mentioned, and then determining those types of questions you need to ask. And the first question would be, I see you injured your toe. Please describe how you injured it. Now, we're not giving you the answers. You're just going to make up. You're going to give me a yes and a no. And on the yes, you're going to say something about it, and you make it up. Do whatever you want to do with it. We don't care. You were delivering a fairly heavy package to a house and stubbed your foot on a planter, then dropped the package on my foot. It hit me right on top of my foot and big toe. So that would be question one. Question two is, did it swell or turn color? No, it just hurt. And then you've got your differential diagnoses out to the side. We would have done this like a flow chart, but to be able to make the software do what we need it to do is going to be very, very difficult. You'll be completing this on a tablet computer with a regular size keyboard attached. And you're going to have a blank document there that you can fill out. And on all questions, you're going to put the question, a yes and a no, and the differential diagnoses. And since that one said, did it swell or turn color? No, it just hurt. Led to one thing. Yes, it really swelled up and looked purple red, and I could not get my shoe on for a couple of days. So you're looking at a potential broken bone, moderate to severe sprain strain, soft tissue injury. Did you see a medical provider or have it x-rayed? No. Consider your x-ray. Yes. And see how this goes through? It just follows all of the various questions that you're going to ask. And you continue through with it. And then all of a sudden you're going to see there's some numbness. Because in the history form, the guy said that he had some numbness. So you start looking at numbness and what that could be from. And what about the other foot? So you're looking again at peripheral neuropathy, and is it bilateral? How much of the other foot? What about the hands? And you just keep going through, and you're looking for the various things that the history suggests to you, and you drill down on these questions. The point we're trying to get to is, can you drill down from patient information and really focus in to give yourself a list of differentials that many of them you're going to rule out with your physical exam. and you're looking at all different points of the history. And my suggestion would be that when you go through that history, you look at things that you know you're going to want to ask, and you put a pencil mark or pen mark on that, and we'll provide you with pens. And then when you're going through and filling this out after you've first read the history, and you'll have a whole hour to do this, so you should be able to finish it in an hour. You just go on and ask the questions. Then at the very end, you list your differentials and your follow-up method at the end of it. Nobody is going to talk to you while you're doing this. It's going to be strictly you completing this form from the patient information, and you're making up your answers. You're making up the reason the toe hurts. It could have been any number of things. It could have been it started with an ingrown toenail. That's not the direction I chose when I was filling this out. So, has anybody got any questions about what to do on this one? All right, sounds like you kind of understand this. So now I'm going to go over the physical exam form with you. And once again, this is on the website. First question that's weird looking. First question I'm always asked, that's really weird looking, is, are we going to get a copy of the form to be used in the exam itself? Yes, you are. The exact same form that the graders are going to have, that your associate examiners are going to have. There is a change this year. You don't get to delegate anything to your assistant, to anybody in your clinic. You have to do height, weight, blood pressure bilateral, oxygen, pulse bilateral, and respiratory cycles per minute, and then full and shallow. You have to go through those sections on memory. And I'm going to pull up the actual document because I can't see this. I'm pretty blind. And I'm just going to pull it up so I can see it larger. Okay, then you're going to go through the orientation. You want to know if they know their name, they know where they are, and they know what time it is. And the time is, you're just going to ask the patient. The patient will answer you. They're not supposed to sit there and be mute. They are supposed to interact with you and talk to you, because if they don't, you don't get any information. The examiners are not to talk to you. If you get really, really off the track and you start wandering out doing stuff that is not required and will not be graded, they may ask you, "Doctor, why are you doing that?" or you need to look back at your form. They may say something to you. Also, they may say to you, you need to hurry up. If you're starting to get lagged behind and wrapping yourself in a knot over something, they'll tell you to move along. The memory, recent and remote. You ask a question about recent memory. What did you have at your last meal? What did you eat for breakfast this morning? Or what did you have for dinner tonight? Remote would be, what elementary school did you go to, or who was your favorite elementary teacher? Then you want them to repeat 7 numbers in a monotone. And that would be 2798296. You want to give them to that in the monotone and see if they can give you back those numbers. But you have to do it in a monotone first and then ask them to repeat it to you. And then you do one that's a sing-song. 2389655. And then in the cognitive, you want them to spell the word world forward and backward. And you want them to count backward from 100 by 7s and from 20 by 3. And no, you don't have to go all the way down to 0. You just want to get them to do 4 or 5 subtractions. And then you're going to give them 3 words. You're going to say, dog, I want you to remember these 3 words, and I'm going to ask you about them later. Dog, hat, and chair. And then you just go on. You don't let them repeat them to you then. You just go on. Then you're going to have them smell 2 different smells. And right now it says coffee, but it's not necessarily coffee. It may be peppermint. It may be cloves. It may be cinnamon. any one of those things will be in your scent kits, and we do provide those. So first off, you ask if they can smell it, and then you have them ID the scent each nostril, and you'll change scents between the nostrils so that there's no overlay. Then you do the peripheral vision testing, and then you'll have your Rosenberg chart to do the close vision. You'll want to cover their eye, and you can use an index card or something like that. We don't have any of the cover uncover eye things. I just didn't get them ordered. Sorry. If you have your own, you can bring it. And you're not going to be doing you're not going to be doing the long one, the Snellen chart this year, because there's not enough room in there, and we don't want you just saying you're going to have your assistant do it. That doesn't seem to make any sense. So you're just going to do the close-up one, and you've got to be sure that they're 14 inches away. You are going to be provided with the tape measure. For your pain and pinwheel, you've got disposable pinwheels to use, and you're going to do right and left for each one of these different cranial nerves to do the testing. Corneal reflex, onion skin pattern. You're going to do cranial nerve 7 motor. We are not doing taste. That has been deleted. Apparently, most of the doctors don't do taste. If they do anything, they only do very, very limited, the salt and sweet. You will do a finger rub bilaterally. You will do Weber and Renee. And then you're also going to do the palate to fatigue, and gag. Then you're going to do the SCM and the trap. I would suggest by the time you've finished your peripheral vision, you're going to ask them to say, dog, hat, chair. What were the 3 words I told you? Then when you've finished all the rest of the cranial nerves, you're going to say, what were the 3 words I asked you? And they're going to give it to you. Then on the part with blethospasms, anisocoria, you're going to be observing these things, and you're going to talk out loud and say, well, I'm not noticing any twitches or blethospasms. I don't see, you're going to look at the pupils, and you're going to say, I don't see anisocoria. But you've got to actually look at the pupils the correct way, going in from the correct direction, and you're looking at direct and consensual pupillary response. But that's also when you'll notice your anisocoria. You're going to look for ptosis, and you're going to comment on it. You're going to look for lid lag. You're going to do field of gaze, convergence. You're going to look for tropia and phoria, and you'll need to know the difference and how the technique is different. You're going to note and say out loud whether or not you're seeing any nystagmus. You're going to do an OPK. Now, in doing the OPK, you don't have to go in every single direction that's possible. You have to do horizontal and you have to do vertical. You don't necessarily have to do the diagonals. You do need to state when you're doing it, I notice pursuits are good, return saccades are good, or I'm noticing hypometria in one direction or hypometria, and the tracking is good. For your ophthalmologic, you do need to look for the cup disc ratio, and you do need to look at the AV ratio, and you do need to state what they are. And then you need to do blind spot testing, and you cannot do it with a cell phone. You've got to do it the old-fashioned way, like you're out in the boondocks and you don't have anything but just lighting. You measure how far away from the blind spot chart the person is, you cover the one eye, and you have them do the blind spot testing. And you've got to do it on both sides. The things that require you to do things bilaterally, you do not get credit if you don't do both sides. For gait, you want the person to walk. For dual tasking, you want them to think A and say B. And you can look up dual tasking. There's lots of YouTube videos on that. Homology head thrust, toe walk, heel walk, pull test, tandem walk. All of these different tests you've got to demonstrate you can do. You can have the patient do. You're going to test their muscle stretch reflexes, triceps, biceps, brachioradialis, patella, Achilles, Hoffman, plantar. And this little picture on the side of the human, you're not going to do anything with that. That's just for you to mark it off. A lot of people actually have developed these and used these in their office so that they're using them for charting. That's why some of this other stuff's on here. The pinprick, pinwheel for your upper extremities, you do dermatomes. Proximal, distal, lower proximal, distal, and you do your trunk dermatomes. And I think there's a misspelling in there. Yep, there's a P instead of an O. And your anterior and posterior. Do not try to test the dermatomes through a hospital gown, you will not get credit. Don't test things on the feet with socks on. You won't get credit. Vibration, light, touch, the same thing, proximal and distal, proximal and distal. Then in joint position sense, you do the distal first. You do the thumb and you do the toe. And if those are both present, you don't have to do proximal. If the patient actually doesn't get the joint position sense on the big toe correct or the middle toe correct, then you've got to go a little more proximal to see where it starts to locate, where they start to be able to feel it and tell what it is. For posture, you need to look at them anterior, posterior, and laterally. For your muscle tone, I'm giving you this advice because it's really hard for the associate examiners to tell if you do muscle tone and rigidity at the same time you're trying to do strength. They can't tell if you're doing it passively, and they won't give you credit for it. So I would suggest you go through your tone and rigidity all the way through, and then you start doing your strength. It just makes it a lot easier for them to see it, and you want them to see your technique. That's what you're being graded on. You're not going to come to any conclusions on this. You're just demonstrating technique. And you'll have 45 minutes to do it, to demonstrate all of this. And you're going to do your strength in all of those different areas. The range of motion, you're going to do cervical and dorso-lumbar. And then you're going to do LFCC and MFCC. LFCC is lateral flexion, cervical compression, and MFCC is, I always forget that one. I think it's, I'm not sure exactly what it is, but I will send it out to you. If one of you knows, type it in there. It's always a question that everybody wants to know what it is, and I will send it out in an answer to everyone. Then you're going to auscultate the heart. You're going to take an apical and radial pulse, and you have to have the stethoscope on your ears while you're taking the apical radial pulse. You've got to be listening to the heart and taking the radial pulse. You need to listen for carotids, and you need to do temporal. You don't need to do ocular. You'll need to do the Valsalva, and you will need to count it, and you will need to have the stethoscope on the person's heart when you're doing it. The capillary refill, you'll do your radial pulses bilaterally. You'll do your pedal pulses bilaterally. And the markings there are merely, if you're going to use this in your office, because we're not taking these up and saying that you've provided the correct answers. We're looking at your technique of obtaining those answers. The video clips are what we use to see if you know what you're seeing. You're going to talk about the patient's facial color, the hands, look at them, look at the feet, look for varicosities in the feet and the legs, look for edema in the hands, the upper extremities, the feet, and the lower extremities. And you'll want to note whether, if it's pitting or not. So you'll need to test for pitting edema. For respiratory, you're going to auscultate the lungs, then you're going to percuss, and then you're going to do the rib expansion in that order. For the abdomen, auscultate first, then you do your reflex, then you percuss, then you palpate, and you talk and you tap, do the tamponade thing to see if there's any distension. Not tamponade, but tympany. For endocrine, you're going to palpate the thyroid and the lymph nodes, anterior, posterior cervical chains, and the axillary. Nothing more than that. Skin, you're going to talk about if the skin's dry, it's cold, it's hot, it's sweaty, and you're going to look for lesions and say, I don't see any lesions on the upper extremities or the lower extremities. I'm not seeing any on the trunk or the face. And the nails and cuticles, bitten nails, cuticles torn, nails and cuticles manicured, and you just make the comments on it. For the observations, you look at spontaneous movements and you say, I don't note any spontaneous movements. I'm not seeing any tics. I don't hear any spontaneous vocalizations that were unintentional. For intention tremor, you need to have them reach for something. For essential tremor, you need to state that you don't see it. For ballistic, you need to toss them something. For choreiform, they of course are supposed to be relaxed, so you're just looking and you don't note that you don't see it. And you have them move to see if there's any dyspraxia. For the additional tests, you can Google these and you can get them on YouTube. And there's some really excellent examples of every one of these things on YouTube. So that shouldn't be a problem. And only these tests. If you do 6 other things that you think are just wonderful things you ought to be able to demonstrate, that's great, but you're not going to get credit for it. We don't take away credit. We just give the credit for the things that you do that are on this sheet. And we have to stick to this sheet, because if we don't, then everybody's not getting graded the same way, and we have to do that. The video clips are what people really usually get thrown about. And the 2 websites on the ACNB website, there are the primary references. You'll need to download that document and look at it. The ones that are going to help you the most for your video clips are library.med.utah.edu neurologic exam. That one is absolutely correct. All of the things on it for the normal and the abnormal are correct. Watch it repeatedly. For the other one, the www.neuroexam.com/neuroexam, it's another site, but it is incorrect, not correct on joint position sense. Don't do it that way. Look at these 2 websites. Really go through the entire neurologic exam with that. I would also use the book Campbell and DeJong and Herrera's DeJong's The Neurological Exam, and DeMeyer's Technique of the Neurological Exam, 5th edition. Those are the 2 that we use. Also, use anything that Dr. Brock told you to do in the review, and if you haven't done his review, you need to get it, because I believe that it is available on DVD or streaming or something, that you can get it even if you didn't get to go see it. That's your practical exam. You're given an hour for the history. You're given 45 minutes for the physical exam, and you're given, I think you're given an hour. I think you're given an hour for the physical exam. It's really close to an hour. I think you're given an hour for that, and then you're given 45 minutes on the video clips. There are 18 video clips. You will be tested over, do you know what retinas are supposed to look like and what abnormalities on retinas are? Do you know eye movements? You get an eye movement video. Can you tell when there's anisocoria? Can you tell when there's a palsy of some sort? And every one of these video clips, you see the question and you hear the question, because we give you a notebook and it's got the question in it. We've decided that since not everybody speaks in the same type of dialect, and many of you speak different languages, we have written out the script of each of the video clips that has vocalizations. So you'll be able to read what the doctor and the patient are saying to each other, as well as looking at the video. You can watch each one of them twice. My recommendation is you turn, you look at it, you read that script, and then you say play the video, so that you can actually be really watching what's going on, but you do have that script there. You'll see gait, you'll see range of motion, you're going to see any of those things that are on this physical examination are fair game for video clips. You will not see things that ask you what color it is, because we can't guarantee the colors on the cameras are all going to, on the computers that are showing it are all going to be the same. So we won't do anything that has colors. We're not doing heart and lung sounds. So those are some things that we have not done, and you won't be getting those. But you'll get cerebellar type things. You're going to get reflexes, sensory testing, know your dermatomes, and know what those dermatomes mean, and know what sensation, what nerves feed which dermatomes. Are there any questions? I've whizzed through this. Yes, you will have this entire exam, the physical exam sheet, the whole time. You do not have to memorize it, but I would suggest you get to do it regularly so that you are very familiar with it, that you just flow through with it. No, you don't have to memorize it. Yes, you check it off. You would be checking off a sheet in your office. The correct examples are on the first. It's the library.med.utah.edu/neurologic exams. That one is absolutely correct. The only thing wrong on the other one is the joint position sense, and that is again on that website. It's on the primary. I've listed that incorrect item on your primary references page, so you're not gonna have a problem with that. You fill in the yes or no. On the history, if you put yes, then you need to put something to it like, did you injure yourself? Yes. How? You need to make sure that you put down a how, because that's not going to tell you a whole lot. If you're the doctor asking the patient questions, you would want the patient to say something. So you could, my toe hurts. Did you injure it? Yes. What did you do? My dog bit it. I'm cutting up. Can I post the findings? Okay, you are cutting out. Can you post the website? Everything you have to provide a yes and a no to each question. That is correct. You have to put a yes and a no on each question. And you have to, if it's a yes, you have to write a little bit about it. I'm not typing well. HSTORY. And give detail to the yes. Are you understanding that better? Okay. Remember, I can answer any questions you have as long as you send them to me in writing, and I can get the answers out to everybody by June the 6th, because the first practical exam is June the 7th. After that, all I can answer are logistical questions. I cannot answer content questions after that. So be sure you're aware of that. I will post that little tidbit of information on the homepage of the website as well. Get used to using our website. It is very helpful. You need it. Yes, hang on and I'll get that for you. In writing, I'm not locating it really easily right now, but I will get it back to you in writing. I know LFCC is lateral flexion, cervical compression. Respiratory, do we need a watch with the second hand? probably wouldn't hurt if you've got one, because I'm not providing that. The equipment that you can do this entire exam with the equipment provided. If you want to bring your own equipment because you're more familiar with it, you're welcome to do so. We don't mind. But you can, we send all of the equipment. Findings such as, no, you don't have to grade the muscle strength onto the provided exam sheet. You just have to demonstrate the technique. You may have to rate one from a video clip, but you don't have to. We do not have Panoptics. We've got the old school cheap fundoscopic ones. So if you want to bring your Panoptic, bring your Panoptic. I'm still looking for that LFCC, MFCC. And I'm just flat not seeing it. I'm just not seeing it. Any PD grading on the videos. What does PD mean? Yes, I've taped the whole webinar, Dimitri. Oh, maximum foraminal compression. You got it. Good, Mark. Thank you. Any PD grading on the videos? Parkinson's grading on the video. You may see some Parkinson's, but I'm not sure you're going to see grading. I'm not sure exactly. I don't think you're asked to tell how severe it is. You're asked to recognize what you're seeing. If it's a Parkinsonian tremor versus a red nuclear tremor versus whatever else, you will need to know the difference there, and you will see some of that. I would really suggest you look at a lot of YouTube videos of neurological exams, and if you Google those, you're going to get a ton of them. Just be aware that not everything you see on the internet's correct. And also, videotape yourself doing your physical exam, because you may think you're doing it correctly because you've been doing it that way for a lot of years, but videotape yourself, then look at your video and compare it to both the websites and to the DeMeyer or the DeJong. Because if you're doing it incorrectly, you're not going to get credit for it. Can you leave the sheet blank on the physical exam? Yeah, you don't need to write on it. We don't care. It's just for your benefit. You can use it as scratch paper. You can throw it away. You can do whatever you want to with it. But that is what you will be graded on, and you do have it during the exam. And yes, you'll have access to the whole beginning because I have recorded the entire webinar. You don't have to go in order. But remember, people are trying to grade you, and they are looking at that. And if you're skipping around all over the place, they're going to have a hard time seeing it, and you may not get credit for some things you've done. Do your examination systematically. If you are skipping around and it's not systematic, you're going to miss some stuff, and they're not going to be able to catch you. You need to either do all of one tool, or we have clipboards. We have plenty of clipboards. But I would suggest that you go in as much of this order as you can, unless it's really not the way you do your head-to-toe physical. But so long as you've got a systematic way and they can keep up with you on the grading sheet, that'll be fine. We don't require it to be in this order. Any other questions? Don't be late. You're still unclear on the history. Okay. What you're going to do on the history is you're going to go through, you're going to have an hour, and you read through the history form that you're given. And I've given you a sample one of the guy with the sore toe. You're going to read through it, and if I were doing it, I would mark the things that I need clarified. Like, okay, you got a sore toe. Did you injure it? And I would mark those things. If there's a family history of diabetes, I'd mark that so I could ask about it. If there's a car wreck that was in the history of the injuries, I'd mark that and want to investigate that a little bit more. Yeah, it's you can write all over it. You bet. You can write all over the history form. And then you start on the actual questions and you put in the question, and it'll make it easier on grading it if you've got a train of a question like, did you injure your foot? Did you have it x-rayed? Did you take an antibiotic? Those are all in the same chain, so that would be better if you listed that as question 1, A, B, C, D. You don't have to do that. Don't get it screwy. But yes, I will confirm the time and I will email it out to everybody. If I have to search the computer for it now, it's just going to waste your time now. I will email you out the exact amount of time you're getting for each one of these exams. I'm pretty certain it's an hour for the physical and 45 for the video clips, and it is an hour for the history. In practice, the exam form typically only marked for abnormals. We use this form every day and only mark abnormals. That's fine. You're not going to they're going to collect up your physical exam sheet, but we're not going to look at it. We don't care what you mark. You don't have to mark anything. We're looking at your technique on the physical exam sheet. Oh, the real world question. Everybody uses their own methodology. I know you mark abnormals, but some people like to do normal as well, so that if something has been normal all along and then it suddenly goes abnormal, they've at least got the verification that they did check it before and they can verify it was normal. That would be, within normal limit is fine. And I would mark it. If this is a real world question, not a test question, in my clinical practice, I would definitely mark it. I'm an RN, not a chiropractor. I'm a PhD neuroscientist, but I did a lot of legal cases and transcriptions and advised a lot of lawyers on when to go after something. And if the documentation is not there, like vital signs, if you just put within normal limits on your vital signs, you're going to be in trouble. You need to actually list out what those vital signs were. And as a functional neurologist, that's really critical to your practice. So all skin within normal limits, just right on the whole box, WNL. Yeah, you may want to give a little bit of information about that. I can't imagine an entire skin on an entire person not having anything that's mentionable, like a lot of brown spots or highly freckled or has several small moles that appear to be benign. I can't imagine somebody having skin that's totally within normal limits. What is complex CN function? Oh, that's not. It's swallowing, and that's because it takes more than one cranial nerve, and so I wasn't able to put which cranial nerves are swallow, so I just put complex cranial nerve function. It's just the swallow. That's all. Is that clear? Okay. Any other questions? I am in sincere hope that the recording is also recording your questions, because it's a screen recording, so it should be recording all of those questions. Again, later in the summer, during June, I will do a complete webinar like this for the written exam. But right now we're dealing with the practical because some people are taking it next week. I will not answer content questions on the practical exam after June the 6th. Only logistic ones. And once again, so nobody's distracted by it, the little puff all the time is my oxygen. That's all I have for you. If you're through, you're very welcome. This is all practical only, Joe. You're all very welcome. Stethoscope with the apical radial, not just the radial pulse, stethoscope with apical radial. You can use the pulse oximeters for the radial pulse. Probably about June the 16th or 17th for the written webinar. My time frame is really cracked until then. Finger tapping frontal tests. What are you talking about? Rebecca, email me your whole question and I will answer it for everyone and email it out to everybody. Okay? Thank you. Have a great evening and good night.